Our next speaker is Rehl.
Okay, thank you very much. So over the next 10 to 15 minutes or so, we're going to cover sinusitis subtypes. We'll talk about how to recognize diagnostic pitfalls when we're trying to diagnose a sinusitis patient and understand at the end appropriate use of antibiotics in sinusitis. So how many here this week treated sinusitis? Yeah, so it's very common. 1 in 8 in the US population will say that they've seen a provider for a diagnosis of sinusitis in the preceding year. So sinusitis categories, all you have to remember is it's all about duration of symptoms. So we break up sinusitis into different categories based on how long the symptoms have lasted. So acute rhinosinusitis is going to be symptoms that are less than 1 month. And there are two main types of infectious sinusitis, viral rhinosinusitis and acute bacterial. Subacute rhinosinusitis is when the symptoms go beyond 1 month up to 12 weeks. Recurrent acute is going to be that patient that gets 4 or more episodes of acute sinusitis per year, and they're normal in between those episodes. And then chronic rhinosinusitis is 12 consecutive weeks of sinus symptoms or longer. And that's going to be outside the scope of this talk. So sinusitis, again, it's a clinical diagnosis. When you're talking about acute sinusitis, it's all about the symptoms. This is a comprehensive list of sinusitis symptoms. I just want to emphasize that these top 6, these are really the high yield symptoms. So these are the cardinal symptoms of sinusitis right up here. These they can have, but they're not as important. And we talk about the cardinal symptoms of sinusitis so we stay on track and we can avoid diagnostic pitfalls. It's important to know that there are many diagnoses and many conditions that can masquerade as sinusitis, and patients will come into your clinics, our clinics, thinking that they have sinusitis when in fact they may not. So things like temporomandibular joint disorder, migraine, tension headache, cluster headache, and a dental abscess, all of those things can be misinterpreted as sinusitis because they will cause pain and pressure in the first and second divisions of the trigeminal nerve, and the patient, for some good reason, will think that they have sinusitis because of that. So again, to avoid those diagnostic pitfalls, I'm going to draw you back to the cardinal symptoms of acute sinusitis, and that's purulent nasal discharge. And more accurately, this is a mucopurulent, so it's mucus mixed with purulent secretions. And that discharge can be anterior or posterior, so it may be dripping out of the nose, or the patient may blow it out of their nose, or it can be posterior, where it'll drip down the posterior pharyngeal wall as postnasal drip. Facial pain, facial pressure, facial fullness, nasal congestion, and nasal obstruction. So to remember those cardinal symptoms of acute rhinosinusitis, I like to lump them together and call them the 3 Ps. So the first P is purulence, which refers to the mucopurulent nasal discharge. The second P is pressure, and I lump facial pain, pressure, fullness all together in that. And then the third P, plug. Their nose is going to be plugged. They'll either be congested or obstructed. You may also be familiar with the PODS mnemonic. How many have used that or been taught that in school? So the PODS mnemonic, the P is pain, pressure, O is obstruction, D is discharge, S is smell disturbance. So diagnosing acute rhinosinusitis is actually difficult for otolaryngologists, it's difficult for primary care providers, and so there are clinical practice guidelines that have been put out there by the American Academy of Otolaryngology, the Infectious Disease Society, the American Academy of Family Practice. And I may be biased, but I think the American Academy of Otolaryngology clinical practice guidelines are the best. They really keep me out of trouble and keep me on track when I'm trying to diagnose acute sinusitis. So they tell us that you diagnose acute rhinosinusitis when the patient has symptoms up to 4 weeks. They have purulent nasal discharge, which is an absolute must. They must have mucopurulent nasal discharge. And then they can either have facial pain, pressure, fullness, or they can have nasal congestion, or both. And again, I like to simplify things, so I always think the 3 Ps when I'm seeing these sinusitis patients. Do they have purulence? That's a must for diagnosis. Are they having pressure in their face, facial pain, pressure, fullness, and are they plugged? And again, that keeps you away from the diagnostic pitfalls of temporomandibular joint disorder, migraine, tension headache, and cluster headache, because none of these are going to have mucopurulent nasal discharge. So just remember, you can't diagnose acute sinusitis without mucopurulent nasal discharge. Do you need imaging to diagnose acute sinusitis? No, you do not. If you meet the diagnostic criteria to diagnose sinusitis, you don't need any imaging studies, okay? And the reason for that is because patients with a cold, patients with viral rhinosinusitis, and patients with acute bacterial rhinosinusitis, their CT scans or their x-rays, they all look the same. They're all going to be abnormal. So you can't really tell the difference. So it's not helpful. And that's why sinusitis is really a clinical diagnosis. A brief note on plain x-rays, the Waters view, the Caldwell view, they're just not indicated. They're not sensitive enough. And in fact, the American College of Radiology came out with a consensus statement in 2013, and they just said, don't get them. Shouldn't be getting them. They're not sensitive. They have no role in working up sinusitis. So you can stop worrying about ordering plain films. CT is really the workhorse of imaging in sinusitis. It doesn't really have a role in acute rhinosinusitis, however, because you're going to look for those diagnostic criteria unless you think the patient has some alternate diagnosis. So that might be the patient who's the frequent flyer coming into your clinic frequently. Oh, I have another acute sinus infection. And you're thinking, well, they really don't have mucopurulent discharge. So you might get the CT to rule out sinusitis. You might get the CT because you think they have something else, okay? And then we almost always get a CT in the chronic sinusitis patient. So that's somebody who has symptoms for 12 weeks or longer, but that's outside the scope of this talk. MRI has a very limited role in acute rhinosinusitis, and you're going to get that when you think the patient has a complication in their orbit or their brain. So those patients are pretty sick, or if you think they have a tumor. Brief note, viral versus bacterial sinusitis, because this is really one of the main points of the talk too. So viral rhinosinusitis, very, very common, 2 to 5 times per year in the average adult. Only 1% of viral sinusitis infections are going to convert and become bacterial. Viral illness symptoms usually getting better by day 5. This is interesting. Fever and facial and dental pain do not predict bacterial infection. And then this is even more interesting to me. I was always taught early on in my training that purulent nasal discharge meant a bacterial infection, and in fact it does not. So purulent nasal discharge does not mean that the patient has a bacterial infection. It just means there's neutrophils there, and you can get that in a viral illness. So viral rhinosinusitis, remember it's one of the 2 types of acute sinusitis. All you need to remember is viral rhinosinusitis is acute sinusitis symptoms present for 10 days or less. And acute bacterial rhinosinusitis is sinusitis symptoms present for 10 days or longer, or greater than 10 days, I should say. So again, those 3P criteria, they have to have mucopurulence, then they're either going to have facial pressure, or their nose is going to be plugged, or both. But this seems kind of arbitrary, doesn't it? Like we just decided 10 days. And if you have symptoms less than 10 days, you don't have a bacterial infection. And then on the 10th day, you have a bacterial infection. But you know, we need something to help us in clinic, right? So that we can be definitive with patients. But where this comes from is old studies where they did antral punctures on patients, and they would actually puncture into the sinus, aspirate purulent fluid, culture it. And what they found was when they did that prior to 10 days of symptoms, their cultures were predominantly negative. When they did that after 10 days of symptoms, they were positive. So that's where that comes from. Seems arbitrary, but it's not. Now, the other way you can diagnose acute bacterial sinusitis in less than 10 days. There's a little bit of a workaround, and that's called the double worsening phenomenon. So that would be a patient who has sinusitis symptoms for 5 days. Then they start to get better. And then, boom, on the 8th day, they get acutely worse. That's also a sign that the bacteria are flourishing in that stagnant mucus in that sinus. So that's the other way they can get it in less than 10 days. But just remember 10 days, and that'll help you. All right, so you've diagnosed viral rhinosinusitis. You're seeing that patient in your clinic. They meet the 3P criteria, so you're calling them sinusitis. but they're 8 days of symptoms, so they're not bacterial. Well, you're not going to give them an antibiotic, obviously, but you're still going to offer them some treatment. So you can spend some time counseling the patient so they feel like they got something out of their copay. You're going to offer them analgesics and antipyretics, so you can send them to the pharmacy to get acetaminophen, ibuprofen. That's going to help with the fever and the facial pain and pressure. Good research studies tell us that nasal saline irrigation and a couple of week course of topical nasal steroids can help diminish their symptoms and get them over the viral rhinosinusitis quicker. So both of these things are available over the counter. There's not great supporting evidence in the literature for these things, but the clinical practice guidelines say you can offer it to the patient. Oral decongestants, which I like to recommend to relieve that pressure and help open their nasal airway. Topical decongestants, which I love for 3 days to give them an airway so they can at least sleep and start to get some relief from the nasal blockage. It's miserable to have your nose blocked. Oral antihistamines can help cut down on the hypersecretion they get. Mucolytics to keep that mucus thin and flowing out of the sinuses. And then cough suppressants. I don't really like to do that. I feel like I want them to get that stuff up. I want to get it out. But if they're miserable and they can't sleep, then sure, we'll suppress the cough so they can at least get some sleep. Now, they've gone past 10 days and you've diagnosed them with acute bacterial sinusitis. The clinical practice guidelines say you can either, 1, do observation and defer antibiotics, or 2, you can give them antibiotics. What does observation look like? Well, that's when you tell the patient, most cases of sinusitis get better. Bacterial sinusitis gets better most of the time without any treatment at all. So we're going to give you 7 days to get better on your own without giving you an antibiotic. And here's the data to back that up. So 4 randomized controlled trials, this was the meta-analysis of that, 86% of cases of acute bacterial sinusitis will be better in 1 to 2 weeks without antibiotics. When they gave antibiotics, that number went up to 91%. So really not much of a difference. So the vast majority of cases of acute bacterial sinusitis is going to get better without antibiotics. Now, if you are going to observe and the patient is okay with that, you just want to make sure that they're trustworthy and they're going to follow up with you if they get acutely worse and their eye puffs up or something like that. So if you decide to not give that patient antibiotics, there are still some things you can do. Just like the viral group, you can say, okay, analgesics and antipyretics are helpful for you. Topical nasal steroids and nasal saline irrigations, just like in the viral rhinosinusitis group, those have some benefit in the acute bacterial group you're observing. Topical decongestants, again, antihistamines. There's benefit in allergic patients, but for some reason, they're different than the viral group. In the studies that they didn't find any benefit in the non-allergic patients, but reasonable to offer it. And then oral steroids. So this is you giving oral steroids without antibiotics. There was no benefit to doing that. We'll talk about oral steroids with antibiotics here in a couple slides. Now, the other thing you can do if you decide to observe and not give an antibiotic, you can do something that just kind of helps mitigate your patient's anxiety. You can give them what we call a SNAP. A SNAP is a safety net antibiotic prescription. You can just say, look, you're probably going to get better without any antibiotics, but I know you're worried about getting back in here to see me. I know you're worried that if you get worse, it's going to be hard for you to get a script. So I'm going to send your prescription over to the pharmacy. Don't pick it up, don't take it unless you get worse or you don't get better in 7 days. So that's a SNAP. Now, let's say you decide to treat. So the patient's 10 days and they don't want to observe, you don't want to observe, you just want to give them the antibiotic. Clinical practice guidelines give us some really just discrete advice. They say, okay, if you're going to give antibiotics, you want to give amoxicillin or amoxiclav. They don't differentiate, they say either or, and you want to give that for 5 to 10 days. So I just say, for me, I give Augmentin. If I have diagnosed acute bacterial sinusitis, I give Augmentin. I give it for 7 days in the acute bacterial sinusitis. This is not a chronic sinusitis patient. This is acute bacterial. For those penicillin allergic patients, I give doxycycline for 7 days. If they're allergic to that for some reason, then I will go to levofloxacin or moxifloxacin. I just like to I don't like to go to that just because of the risks of tendinitis, tendon rupture, and stuff like that. For patients who can't get this because they're allergic, can't get one of these, as long as they're not anaphylactic to penicillin, you can give them a cephalosporin combined with clindamycin. The rationale for those recommendations comes from studying the bacteriology of acute bacterial sinusitis. Thankfully, this has not changed much in 20 years. So since I was in medical school, it's still the same. I just want to bring your attention to the beta-lactamase production. Beta-lactamase production is significant in these bacterial populations, and that's why I start with Augmentin, because Augmentin can overcome that beta-lactamase production. I would just prefer to start there and not give amoxicillin. Duration of therapy, why 7 days, why not longer? That was looked at, 12 randomized controlled trials. They looked at comparing short duration antibiotics, that's the 3 to 7 day group, to intermediate, 6 to 10. And there was no difference in symptom control and getting them over the sinusitis. The only difference was that the longer group had more side effects, more diarrhea, more yeast infections. What about oral steroids? There is benefit in the literature. Cochrane systematic review showed that there is benefit looking at multiple studies. The key is to keep it to a short course and counsel the patient regarding the side effects. But in my practice, I do believe that there's a definite benefit when you add the steroid with the antibiotic. I don't do it for everyone. I look at their comorbidities and how the risks might impact them, and also how severe their sinusitis is. But if they have a severe sinusitis, not a lot of medical comorbidities, I'll hit them with a short course of a steroid too. What if they don't get better after you've given them antibiotics? So if they're not getting better in 7 days with an antibiotic, you want to reevaluate that patient and check and see, just make sure you don't have a complication like periorbital edema, proptosis, vision change, severe headache. If the patient's not getting better and they're displaying these symptoms, this might be a patient you want to send over to the ER or call your favorite ENT consultant and get them into their office that day so that they can get worked up and make sure they don't have a complication. If the diagnosis is still uncomplicated acute bacterial sinusitis, just switch their antibiotics. So if you started with Augmentin, go to Doxy. If you started with Doxy, go to Levaquin. Just work through like that. You can also go to a high-dose Augmentin. I didn't include it here. I don't do that. It kind of makes me uncomfortable with the GI side effects. So summary, here are the take-home points. Acute rhinosinusitis diagnosis, you have to have the mucopurulent nasal discharge. So you can't diagnose acute rhinosinusitis without mucopurulent nasal discharge. They're also either going to have facial pain, pressure, fullness, or nasal congestion. And those are the 3 Ps, the cardinal symptoms of sinusitis. Acute bacterial rhinosinusitis is symptoms greater than 10 days. And then the treatment options are observation, because the vast majority of people get better without antibiotics, observation with a SNAP, or Augmentin, Doxy, or levofloxacin. That's it. Yes, Tracy.
So you mentioned on the treatment options in kids who can't do Doxy or Levaquin. I just do a cephalosporin alone, usually Ceftonir. I don't do Clinda too. Should I be?
No, I wouldn't. I don't like Clinda with a cephalosporin, generally speaking, because I'm worried I'm wiping out their microbiome. And so, I mean, obviously you see a lot more kids than I do with sinusitis, and I think anecdotally, if that works well, that's good. There are, by the way, separate pediatric guidelines. From the American Academy of Pediatrics, but this is the American Academy of Otolaryngology. But that sounds very reasonable to me. Boom, cephalosporin like Omnicef or something. Yeah.
Your opinion on zithromycin 500 milligrams per 5 years?
I mean, I don't start with it. Just I try to stick to the guidelines.
If you have people that I can't take this, I don't like that.
Yeah. Yeah, I mean, yeah, if you're whittling down away all of your options and that's all you've got, I think it's very reasonable. The nice thing about that is it's a macrolide antibiotic, so in theory it has some anti-inflammatory effect as well. So,
I think there's a 30% immunity resistance for Zithromax. So you just got that 1 in 3.
so what I'm going to do is we'll get on to the next session because it's a panel and it involves sinusitis, and we can do more sinusitis questions during the panel.